this idea of mitochondria, if we understand it, what is mitochondria? It's the energy driving force. And we go back to
Right.
what we learned in year one in medical school, or in, even in high school, that the role of mitochondria. So I think what we need to do is, inflammation, where there's a lot of good work going on, and not inflammation like I got an infection because I got
Right.
a cut, but what's going on in the brain. So we're talking about the neuroinflammasome as being important in depression and anxiety. I think it plays an important role in concussion.
Welcome back, everyone, to Wellness at the Speed of Light, episode number 5, where we talk everything wellness and go down that wellness rabbit hole. Today, we're really pleased to welcome a very, very special guest, Dr. David Barron, an esteemed, world-renowned psychiatrist who is currently serving as the Senior Vice President and Provost of Western University of Health Sciences since 2019. He's been a beacon of leadership, driving forward the boundaries of health science education with a vision rooted in excellence and innovation. He embarked on his illustrious journey in medicine and psychiatry with a foundation laid at some of the most prestigious institutions in the country. He first earned his degree at the Philadelphia College of Osteopathic Medicine, followed by a residency at the University of Southern California, a place where he would later leave a tremendous mark as a professor and a leader. This formidable training ground prepared him to navigate the complexities of mental health with a blend of compassion and scientific rigor. His current research interests include ADHD, concussion in sports, global mental health literacy, neuroimaging of concussion, depression education, community health, and the role of mental health in the primary care world. In addition to his remarkable career in medicine and academia, his commitment to global health and education is tremendous and demonstrated in multiple ways. He's done multiple Fulbright tenures. He's had multiple prestigious appointments, which has taken him all around the world, fostering international collaboration and understanding in mental health and mental health care. These experiences not only highlight his global impact, but also his dedication to enhancing psychiatric education and practice all around the world. He's been the deputy dean of the Keck School of Medicine at USC, and his leadership in academic affairs has been pivotal. He's had tenure as professor and chair of psychiatry, showing a commitment to nurturing the next generation of healthcare professionals with a keen focus on mental health and overall mental health inpatient care. He's had a tremendous background in sports psychiatry, and dating back to 1984, he's been involved in the Olympic Games, and most recently was at the 2022 Games in Beijing. He's got a distinctive approach to psychiatric care in elite athletes, and his career really demonstrates a critical balance between physical prowess of these athletes and psychological resilience, which is a vital component of athletic success and well-being. Through his many leadership roles, such as the secretary of the World Psychiatric Organization and the president of the Pacific Rim College of Psychiatrists, he's been at the forefront of the community in destigmatizing mental health issues and improving psychiatric care globally. His scholarly work include seminal publications such as Clinical Sports Psychology, An International Perspective, and Essentials in Psychiatry and Primary Care. This has enriched the field of psychiatry. His list, honestly, of publications, lectures, and other things he's been involved in are way too long to discuss here before we bring him on the show. His career is just a mosaic of groundbreaking achievements, unwavering dedication to mental health advocacy, education, and patient care. His tenures all around the world and his commitment to Olympic psychiatry is really incredible. I have no other words for it. As we welcome him today on the show, We're so excited to really ask him questions ranging from sports psychiatry, concussion medicine, his experience in the Olympics, addiction medicine, ADHD, the current state of healthcare and how much we're focusing on mental well-being and the state of happiness. And so without further delay, we're welcomed and pleased to bring him on our show today. You know, you're a third generation psychiatrist.
Correct.
What was the thing that you just said, hey, this is the thing for me?
You know, it's a great question because my dad and grandfather were both psychiatrists, so I always got a chance to see it. I actually was thinking about going into orthopedics because I was interested in sports medicine. And what I realized was that what really motivated me was trying to understand how people think, feel, and behave. And that didn't fit so well into an orthopedic model. So, I mean, I've been very active in sports medicine for my entire career. But for me, it's, and you know, when my students or residents ask me, what's the best specialty? I said, the best one is the one that you're really excited about. You walk into a room and there's 10 different journals there. What's the one that you pick up that you want to read just for fun? Because life's too short. We all work too hard to get to where we are. I was always fascinated by the brain. Not so much as a neurologist, as understanding the brain as an organ. That's a critical part. I mean, I'm boarded in neuropsychiatry, so I got to have it in brain injury medicine. But I think this idea of what is it about us as human beings that kind of results in the way we think, feel, and behave, and what can we do to improve that to, in fact, make a positive impact on the quality of our life, however we're going to define that.
I'd say, I mean, that's a great answer. So, you know, my next question, pretty straightforward. I see that just from the little bit that we've been talking, I see how passionate you are about teaching, and I've watched some of your stuff on YouTube. And I listen, that is in your DNA to teach others about the things that are doing. You've worn a lot of hats, you know, Provost, you've been chairman of this and that and the other. What do you think? Now, you've had all these roles in academic medicine. What would you say is kind of your most fulfilling part of it? You probably can say all of them, but if there's one thing that you could say, this is the most fulfilling part of what I do.
You know, it's a wonderful question. For me, you really hit the nail on the head. You actually answered it for me. It's the things I can feel passionate about. I can feel I love teaching and supervising for many different disciplines. I mean, the university I'm at now, Western University, we have 8 different graduate schools. We have a vet school. We have a dental school. I love the opportunity to go and interact with trainees in this. And I talk to public policy makers. I've been very blessed to be able to work with ministers of health in some other countries. So the things that really get me going, the secret sauce for me that allows me to feel passionate is the ability to not only teach, but to learn. I've learned so much, it sounds like a cliche, from a student asking me a question, particularly in different disciplines. It's not just this myopic, it's got to be medicine, but a public policy person says, hey, this is great. So how are you going to pay for that? So I think this idea of being able to interact and understanding how all these many pieces of this puzzle come together and feeling passionate to share what I've been taught and what I've learned, but that process of constantly learning and staying focused on, for me, the bottom line is, what can we do to improve the quality of life? And I do, as you say, I do a lot of work with athletes, but it's really the general population. So and I feel just so lucky to have been given these opportunities, and the passion's what drives it.
Well, yeah, I mean, I feel just like, as a spine surgeon, I've always been passionate about everything spine surgery. And that's what drove me. I mean, it was a no-brainer when I was doing my training that I was going to go into spine surgery. I fell in love with it. I wanted to read everything that was out there. Now what I'm finding kind of mid-career is that not only am I passionate about that, but I'm really passionate about lifestyle medicine and everything that we, as a medical group, society need to really get out to the public. And we really need to focus on prevention and making people feel just generally better. And one of the interesting things that I had from one of our other guests was great. He said, modern medicine gave the baby boomers the gift of a longer life. But the question is, how are they leading that life? Are they healthy or are they sick for 30 years? looking out of a window of a nursing home with things that could have been prevented. So now I've got stacks and stacks of books that I'm just pouring through on just everything lifestyle medicine. One of the topics I'm really passionate about is concussion. We'll get to that after. But yeah, that was a great answer. I really appreciate that. I think the next question, the next kind of line of questioning that I want to go down is your tremendous experience in the world of sports psychology. You were there at the 2022 Beijing Olympics, and you are, National Institutes of Mental Health. I mean, you're very, very dialed into that part of that world and being tapped for all these different, hats that you wear. What do you think in sports psychiatry are the most critical things that we all need to be thinking about when we see patients or just as people watching this that are into sports, they're hardcore sports, or their kids are playing sports? What are some key points that you can give to them on sports psychiatry?
Yeah, well, we could do probably a whole weekend on that because, as you said, I was fortunate. I started working with the Olympics back in, as a physician back in the '84 games. I've been blessed to be able to, be at quite a number of games. Yeah. And one of the really wonderful things that I've seen, we got a long way to go, is breaking down the prejudice about, psychiatric symptoms and syndromes. And what's really had the greatest impact, I'd love to say I had a great impact in that, but that would be overly narcissistic and probably not even close to being accurate. What's had to change is the acceptance. So when you have marquee big name athletes, whether it's Simone Biles, Michael Phelps, we can go on and on. There's a fairly long list, but that it was okay to deal with those issues. Again, being involved with the Olympics and high level sports for, many decades now. The difference between the champion and those who aren't the champions is usually not, something as an orthopod, that we say it's that special thing that drives someone to win. So in the area of youth sports, I'm very involved with this now internationally, is I'm really concerned about burnout in youth sports. This is a big deal. I mean, we've got a big 3 or 4 countries we're working. I got a new study we just started looking at this. So why are kids getting burned out? And that's, again, topic for a whole nother discussion. But I think what we're seeing now is victory, whether it's victory in the field of competition, winning the gold medal, or just victory in life. It really has to do with that balance between emotional and physical, that they're not two separate things. Like the best athletes, the best coaches. I was a former athlete myself. The coaches that knew how to motivate in a way that you weren't fearful of it. So I talk a lot about the enjoyment factor. And we have data now that's emerging fairly large, showing that these kids are getting burned out, not because they don't enjoy it, because it's not fun anymore.
Yes.
They're not enjoying it. And so I think what we need to do in the world of sport, I know when I worked the '84 games, I think I was the only psychiatrist that worked in the Olympic Village, because you just didn't talk about that. The prejudice against, psychiatric or psychological symptoms, forget syndromes even. And it's going very slowly, but it's going, I think, in the right direction. And I think the idea of us working together. So I work with sports orthopods. I've learned from them. Hopefully they've learned a little from me, but we all learn from the athlete who is then the patient. So I think what I've seen is an acceptance of the important role of this. We see it in the dark side, the sexual abuse that we see of coaches, unfortunately the Larry Nassar story and, we can go on and on, but the importance of having our head on straight, being in that zone. I think being in the zone as an athlete is about having that sense of enjoyment, focus, and fulfillment, and not dealing with some of the more negative emotions.
I have a couple boys myself, teenage boys that are in sport, and they certainly have had their ups and downs. And my older one plays at a real high level. He's on Minnesota United's their junior team, their U17. So there's certainly a lot of pressure on these kids. Do you think that each one of these athletes, even at the youth level, do you think it should almost be mandatory that they've got some kind of mental health guidance that's just kind of a standard across the board? I know there's resource issues and so many of these things, but should it be that all of them get evaluated for their mental health from time to time, or should coaches be doing that only?
We don't want coaches to feel like they have to be sports psychologists.
Right.
They're out there for a particular reason. What I do believe is important is having coaches appreciate what's going to help those young athletes, not only to perform on the athletic field or in school, but in life, keeping that proper balance. So I think you really hit on a really important point that we're dealing with. Actually, again, we've started some programs internationally where looking at how do we have every youth athlete get the most out of their participation. I'm a huge fan of getting involved with sports, but I'd be lying if I didn't say there are some kids who say, I've just had it. It's just too much pressure.
Yes.
The toxic stress we talk about. To me, sports shouldn't get to that point. To answer your question, I think it is important that coaches get some training on what is your role to not, so you can understand it. Maybe just to identify, hey, this kid's something's mad that, maybe you need to go talk to it, whatever it might be. I don't think we want to pathologize it. We don't want people to say, what do we do? We measure strength, we measure range of motion, we measure hand-eye coordination. I do believe, and we're seeing this in some of the Olympic development programs I'm working with around the world. We've got a couple big projects going on now, is that this should be another factor. So we're calling it the fun factor. When the kids say, it was a tough workout, I'm still into it, as opposed to, I'm just hanging on. So I think you're right. I think we need to expand. It shouldn't just be the psychiatrist, the psychologist. It shouldn't just be the trainer. But what is our particular role? I don't want to tell a coach what plays they should be running. I don't want to tell them how to, how to create, a winning lineup. Even though I played sports, and I want us to be able to work together with the goal of how do we get the most for this. Coaches want to win and lose. When you higher up you go the chain, you get promoted by if you're a winning coach. If you're a winning coach and you're a jerk, they just say you're eccentric. If you're a losing coach and a jerk, you're a jerk and get fired. So we all understand that. So I believe you raised a really important point, and this is one of the things I want to continue to push, is that the mental health of the athlete is an important part of them achieving success, both in competition, during training, and ultimately life success.
What I've seen in now working with a lot of youth through mentorship and through other things, and through knowing a lot of people that are in positions like kind of higher, like principals of schools and a lot of athletic directors, since COVID, the general mental health. So you get the sports aspect of it, but general mental health in the student body populations, without question, has deteriorated. I mean, there's a lot of issues. I mean, it's harder in like disadvantaged communities, obviously, because, school was their one outlet and then things were closed. And what do you think that we need to do on a policy level to start promoting better mental health programs more across the board? Let's just say in the US, because these schools have such limited resources to help some of these kids. I know you're an expert in ADHD, but depression, anxiety, suicidal ideation, I mean, it's off the chart. And these kids, not just in high schools, but now down like to the grammar school level. So is that something you're involved in policy, and kind of what are your thoughts on that?
Oh, absolutely. So to answer that, and again, an excellent question. So I've been invited to the last two G20 meetings that we just had. We just had the one in India, and then before that, and what I was asked to present on as part of that through the SBMT and the G20 is on adolescent suicide, which, as you know, really spiked during COVID. And so and I got involved with that many years ago with the Italian government, looking at, what can we do to improve the next generation of, choosing to kill themselves. I think one of the things we need to do is we need to be very tuned into the subtle and not so subtle prejudice. When we talk about depression, anxiety, it's like only crazy people get that way. I think what we saw during COVID-19 was people say, even kind of normal people can get depressed and anxious based on this thing, that you don't have to be a crazy person. So one of the silver linings of COVID-19, I think, were people to understand that, a life circumstance, a global circumstance can really affect the way I think, feel, and behave. And particularly with kids. I talked about this yesterday. My wife, again, I said she's a coach. They couldn't practice during COVID, but the kids would, the girls would get together and they'd be on social media. So they quote, the first day they were able to get back to practice live, they ran up, they were hugging each other, they were crying, even though they've been singing, because we are social animals and children, we are meant to be with. So I think what I'd like to see us do in working towards an understanding is not to say, well, we're just here to treat pathology, depression, anxiety, whatever. But what you're doing with your podcast, it's about wellness, quality of life. No one gets, there's not a lot of prejudice against trying to improve the quality of life. I think most people can buy into that. So I think our use of language becomes
Mhm.
really important because we are not to the point. I think it's gotten better. People are talking about anxiety, depression, whether it's a mood state or a psychiatric syndrome, but focusing on wellness and what can I do to improve the quality of my life, whether I'm a 6-year-old or I'm a
Mhm.
96-year-old. And that I think it's about wellness, both physical and emotional, which are really interconnected. They're all one and the same. So that's why I really want to thank you for allowing me to be a part of this. But this focus, and I love the idea of the speed of light. We can't wait forever. The longer it goes without doing it, the more difficult it is. For the physicians in our audience, is it easier to treat cancer when you catch it early or when it's, stage 4 level? As an orthopod, is it easier to fix something or try to deal with it when someone's been dealing, for years, that we get compensatory mechanisms that might not be so healthy? So I really love that concept of focusing on wellness and quality of life, but having it be something of urgency.
It's completely urgent, and that's why, even though, I was wearing all these kind of different hats, as a spine surgeon, running the practice and things, when at some point the light bulb went off and said, you know what, I've got a voice in this community and I have to start using it to making differences, because we are treating the symptoms of disease that has been brewing for a long time, and that includes mental disease, right? Because the signs are there and we just don't see it. So as physicians, especially, on both sides, physical and mental, we need to start asking the questions before the pathology arises, because I think
Yeah.
we can make a massive difference. Like I've become like an absolute maniac. I want to almost say it with people's diets and the level of confusion or not understanding into how much damage they are doing to their own bodies with high sugar intakes, with just inappropriate nutrition, consumption of toxins. I can go on and on and on. I know I'm preaching to the choir, obviously, from everything I hear from you, but it's become a mission for me, as and obviously it's a huge mission for you. We'll get to lifestyle medicine because I want to kind of spend the last part of it. I want to just go through some syndromes before we get to the lifestyle medicine, because I think that what you're going to tell our audience on kind of the way that the lifestyle is going to change their it's going to fire their genes, those genes that are tunable, not that 5% you can't do anything about, the other 95% that are going to get turned on and off depending on what they do. So before we get to that, since we were on the topic of sports, I want to get into concussion, where you have done like amazing work. You're on all these task forces and commissions and all kinds of stuff. And I got myself, I mean, I've been peripherally involved with concussion through the years, just covering games and things as an orthopod back in the day when I was at Columbia. But then more recently, because we have a neurosurgical practice, we see so much concussion taking care of patients at a level 1 trauma center. And not just that, but also the subtle concussions, all these little findings. And now I am picking up so many concussions in clinic where I wasn't even picking it up myself. Why? Because I'm asking the right questions about concussion. Whereas before I was like, oh, you have neck pain, you're here for neck pain. But I wasn't asking them, are you forgetful? All these other, headache. We were just attributing that to their bad necks, not to the fact that they took a ding. So you have a tremendous experience in concussion. Could you just give them a little rundown of kind of how you've been involved in the world of concussion and a little bit about your research on concussion and what you're finding?
Sure. And I think concussion was a wonderful way of understanding that if we look at the impact, and I do mostly in the area of sports concussion. I've done a little bit with the military, but that's been my primary focus. You don't want to mess around with your brain for a very long time. But most of the literature that we look at, whether it's a scientific or otherwise, was focusing on traumatic brain injury, where we have a fracture, a bleed, there's something going on. And I've always posited that what we learn about traumatic brain injury is not exactly the same with concussion. And the analogy I've used is if you go into a burn unit where patients have suffered severe burns, from they were in a motor vehicle accident or they were fire in the house, whatever, how much do we learn about sunburn by studying those patients? It's just not a whole lot. So I think what's happened is the TBI literature, which has been around, we can go back to sports, to Martland in the 30s, but that we didn't appreciate that concussion or brain impacts important from very early on. So what I've seen is as we've gotten more education and understanding of it, now we got a long way to go, and there's a lot of stuff out there that I think needs to be studied even more. So I got involved actually through sports. I remember as a kid, as you said, I'm a third generation psychiatrist. My grandfather was actually the ringside doctor at the Dempsey Tunney fight as a psychiatrist, going back a lot of years. My dad worked with the old Boston Patriots, and my grandfather worked with the old Philadelphia Warriors. So I'm showing my age here now. But what you saw, I remember going to an AMA convention when I was just a kid, and there's a guy signing shoes. And, it was African-American guy shining shoes. And he runs up to my grandfather, wasn't a big guy, and gives him this bear hug. And I'm thinking, oh my, what's this guy's attacking him? Long story short, this guy had been a former world champion boxer. And I remember asking my grandfather, why is this guy, a former gold medal and then was a professional boxer, shining shoes in the Fontainebleau Hotel in Miami? And he looked at me, and I made a film on concussion that's been out for a while now. He looked at me and he said, Davey, always take good care of your brain. So that got me into, as a very young age, about the role of brain impacts. I've been able to take care of a number of Olympic and professional boxers over the years. I covered boxing in a number of summer games. And I was always impressed with that, or someone would get hurt and they say, well, you go get a standard workup. Well, we didn't see anything on the MRI, or there wasn't a bleed, so you're okay. So I've had a long-standing interest in understanding the impact of the downstream effect of multiple brain impacts. And sometimes you don't see the symptoms, certainly the psychological symptoms, till sometimes decades later. Well, why is that? That's not the classic. It's not like you get a cut and then, 6 months later you start to bleed. And that's not what we're used to. So I've been interested in understanding the biology of concussion, what's going on, why do we get this kind of mixed clinical picture, these various clinical phenotypes. And what we're understanding now is that this sensitization kindling model, that these multiple brain impacts result in some of these symptoms. And, we have the sports concussion assessment tools. I've been involved with some of those. And, now we just came out with, with the newest scat from the most recent meetings and some recommendations. And the things that I was taught on how to deal with concussion, we now know are wrong. The old mushroom therapy, put them in a dark room for a week and don't have any, now we know that getting them involved within 48, 72 hours, light exercise. So it's been an area that I've found has been understudied. And what's made it more dangerous, we have some people who think they know a whole lot about concussion because they know about TBI. And I would say I've been working in this field for many decades. I still think I'm not an expert in it, but I've tried to contribute and work with some really brilliant colleagues. But we got a long way to go. So again, it's understanding the brain and what goes into alterations in how the way we think, feel, and behave.
Yeah, I think what I've got, I had my my first podcast actually was with my colleague Eric Nussbaum, he a neurosurgeon, world-renowned neurosurgeon. I don't know if you know him personally.
I do. Yep.
Great guy. One of the frustrations that we both share, and obviously he's even closer to that world than I've been, is that over the last several decades, it doesn't seem like there's been a ton of progress as far as how we treat concussion and what is available for people. Because even in my practice, over 18 years, I have seen people are getting the same advice when they go to their neurologist or they go to their, trainer. I mean, they're still good. And to be honest with you, that dark room theory, that's still going. I mean, a lot of that is still happening. People are just told dark room, blue light glasses, it may or may not recover. We can't do anything. They'll send them, they'll do some types of PT and things like that. What do you think is the next? I want to talk to you about a specific modality next, but what have you seen that you feel that there's a lot of potential hope for concussion sufferers? Because it really can I've seen so many people's lives ruined by concussion. Even if it's subtle, it can ruin your life.
Absolutely, because it's not so subtle, and again, they're functioning. So you're absolutely right. There is no kind of approved treatment. I always get annoyed when people say, well, they have a treatment for it. But what we do know is there can be hope. So we know things like avoiding bright sunlight, that can prolong that post-concussive period. We know the critically important role of sleep if we're understanding the lymphatic system. I don't want to get into all that because I know we've got an audience of folks who might not be as familiar with that. But there are things that we can do, not only preventative, but after an athlete has sustained some brain impact, whether they're in, quote, the concussion protocol. So we know about stress, hydration, sleep, critically important. I'm not so sure that anything more than a good, healthy diet. And it's going to be a slow recovery, that you're not going to, it's not like we're going to go do a surgery and you're going to be better in 6 weeks. And there is some interesting work. There's interesting work looking at modulating the brain. There's electromagnetic field.
Yes.
There's a number of people that were looking at the role of the Calpain 2 system. There's some good basic research going on in this. But I think the point you raised is the one that I really want the listeners to understand. There is no definitive treatment, but there are things that we can do that can allow the recovery. There are things to avoid. We talk about screens. I tell all my concussed patients, you're at your computer, cut it back. But instead of sitting this close, sit back, because it's the old 1/r squared, the intensity of the rate. So just sit back. When you're listening to your earbuds and everyone's on those, all right, it doesn't mean you can't use them at all, but dial it back 20, 30%, because we do know overstimulating the brain does seem to expand that recovery period from concussion. We don't want someone to feel like, well, you're basically screwed. Things are just going to get worse. But there are things that you can do. I've had athletes, have had it, take a semester off or take a lighter load, maybe drop organic chemistry, but doesn't mean you can't get back to that. So I think what we need to do is make sure first and foremost, we're knowledgeable about what we do know and what we don't know about concussion, and then work with the athlete. We did a series of tapes for the National High School Coaches Association on training. So what should high school football coaches know about concussion? I don't want them to feel like they have to become concussion experts, but what is their role in this process where they can work with the other members of the team to enhance the performance and the quality of life of these young athletes?
That's a great answer. And universally across the board, I keep asking these questions on concussion, and we're getting the same thing. And it's interesting about concussion that I found, and I mentioned it before. It's like the subtle stuff. As physicians seeing patients who are not in the field, it's interesting because it's like if I tell like my kid to look for, like blue car, right? Then you start seeing those blue cars. You don't see them before that. So now that I'm looking for concussion and asking questions, I'm really blown away by how many concussions we've picked up recently and then tried to get them into the right hands. It slipped through because no one was asking the questions. And the other thing that I want the kind of the listeners to know is, we always ask, well, what are the statistics on concussion? The question is, how many concussions don't we know about that are out there walking around that are impaired?
Absolutely. And it's this whole idea of raising awareness. Like I said, I made a video. This is by full disclosure. I don't make any money off it. It's available for YouTube. It's called Next Week's Game. And we've done it internationally, a number of film festivals. It's really about raising awareness for parents, for athletes, for coaches, and for physicians. I think one of the problems we see is we tended to look for what we learned in medical school or maybe graduate school about traumatic brain injury. And sometimes it's these more subtle symptoms. Plus, as we just said, some of the core symptoms don't really manifest themselves weeks, months, years. The problem with, with the movie Concussion, Ridley Scott, Will Smith, former Philadelphia.
Yes.
I think there were some things that were very good about it, but some things that I don't think were so good. Like there were, poor Mike Webster, had been abused as a kid. Then there was a lot of substance issues. So it's not just the brain impact. I think it's an important piece of a bigger puzzle. So I think to your point and your description of it is really spot on, is if we know what to look for, not like we want to call everything a potential concussion, but if we know some of those core symptoms, and I tell my students, I just want you to just consider, we did a survey looking at PA students about their education in concussion. And then we looked at early stage, we just published that about a year or so ago with medical students. Turns out those who are athletes are probably they are statistically, because they've had to live with it a little more. And the good literature about concussion is relatively recent. Again, you can go back to the 30s. You can talk about a lot about TBI and CTE, which is like a whole nother discussion. But I think what you've shared is what we've tried to do is be aware, know what to look for. It doesn't mean someone has to completely stop, but if you look for it as one piece of a bigger puzzle, it doesn't necessarily have to be the whole puzzle. It rarely is. But I think this awareness, and that's why shows like yours, I think, are so important, that people say, hey, yeah, I'm not going to, every time something is related to concussion, but could concussion or brain impacts, could it have played a role? And if it has, how might that change my intervention? And it might not. So awareness and what to do, and knowing kind of facts from well, I'll spend $500 for a helmet. I'm never going to get concussed. That's nonsense. I mean, can we get helmets that are safer? Yeah, the safest helmet is one that fits well. The biggest problem in high school sports is they wear, it'd like going out and playing a game and having your shoe be a 2 sizes too small or a size too big. That's not so good for, ankle stability and lower joints. As an orthopod, you know this. So I think the awareness and what can we do to keep it in its proper perspective as a potential force in negatively affecting overall quality of life.
Great answer. Great awareness for the audience. I just want people to really be cognizant of how much concussion there really is out there and how much of it is subtle. One of the things that I've gotten really into, we're developing these wellness centers along with Dr. Sipple, who's our medical director. This is outside of my normal practice, but one of the things that we've been looking at is photobiomodulation, transcranial photobiomodulation. Now, there's this study that came out of Massachusetts General that I recently did something on LinkedIn talking about it, but it was a prospective randomized, controlled study. It's like almost 70 patients, and they looked at, they built these special helmets and did transcranial red light, one group and the other group. And not only did they find in the transcranial red light group that they were clinically better at the 6-month mark, but that their brain tracks on MRIs were improved, the white matter tracks. What do you think about transcranial photobiomodulation potentially as something that could be a real tool in the toolbox to treat concussion symptoms?
Well, I think what you said is true. It's another tool in the toolbox. What we now know, so if you look at the world's largest neuroimaging assessment of sports concussion, it's the Enigma group.
Yes.
And so what we know is that with concussion, you're not seeing those gray matter lesions that we might see, but it's a disruption in brain connectivity, how the brain kind of talks and communicates with itself. So there's a fairly robust biology, because now we have the tools that we didn't have when I was in medical school or a resident or earlier in my career. We can actually look at the brain in a way we were never able to do. And that's wonderful. I mean, the advances of neuroimaging, and understanding what's going on in the brain. So that whole tractology, again, those brain tracks is really important. And I think there are a number of potential things out there that might help us improve that. And there's some good data out there. So what I say is, let's keep a real close eye on this. Let's make sure it's good quality science. So there's not a placebo effect, but I think there is science. I mean, I was fortunate enough to do a Fulbright on youth sports concussion back in 2018 up at the University of Calgary, a just superb concussion research group, and worked with a neuroradiologist up there and Carolyn Embry and a number of other folks who are really, I think really just superb and first rate in studying this, particularly in youth. So this whole idea of near infrared and some of these things are coming out. What I'm hoping is that people don't look at it as kind of, quote, alternative medicine or just the way. I think it ties into understanding what's the pathophysiology, what's causing this, and what can we do to potentially modify it. So I'm a big fan of, I think this is being done the right way with good science, having it be placebo controlled. So it's not just, as Benson would have said, a placebo effect, but I think there's really something there. And I think what it does, it also has the secondary effect of, it's not just, well, just suck it up. We glamorize people coming back and playing injured. No, this is like, hey, if you got a broken bone and you can see it, people aren't going to say, you're a wimp for not getting in and playing. I think it affects some of this gladiator mentality. And I think we've gotten away from that. There's still a little bit ways to go, but I think we've really made great progress in the world of sport. So I am a fan of these things. I think we need to do it the right way. And I think we are. Do the studies, look at it. It's not about selling something, but it's about understanding how these interventions might be correcting an abnormality that's then in brain connectivity, brain functioning, that's leading to these symptoms that we see that oftentimes go missed.
Yeah, absolutely. I think on the the transcript, like the near infrared stuff, only a small amount penetrates the skull. Pretty fascinating
That's right.
stuff. I looked at some
and not very deep as well, right?
3%, yeah, 3% in the Harvard study. Only 3% penetrates the skull. But there's more powerful lasers like Dr. Henderson's using with some of these NFL players. His data is pretty outstanding in some of these players. But the interesting thing is, and this is something I actually talked about with Nussbaum, it's so interesting to sometimes then go back to some of the stuff we learned in medical school and drill down. And what's been fascinating to me is, and my wife only allows me to, I've said this on other podcasts, she only allows me one time a day to say the word mitochondria because it's driving her nuts. That's all I talk about in our house. With my kids, I'm like, mitochondria, that's the key to everything. But it's interesting the way that that near infrared works as penetrating that mitochondrial wall and then potentially improving those pumps without getting into all the details. Because part of it, if you really drill down to it, in the research that I've done, and again, I'm no expert at this stuff. I'm learning from people like you, but those pumps get disrupted instantly when you have that traumatic injury, and potentially repairing them through near infrared and infrared type light it's just fascinating that science is starting to get to a point where we may be able to offer different modalities. And certainly, like in our wellness clinics, we've been using it and we've seen really good results. But again, we're not doing it in a controlled fashion. We're just seeing anecdotal, phenomenal improvements in people's concussion symptoms. But again, it has to be done by the Harvards and the other institutions that are looking at these things in a very controlled fashion, because there's other factors. And you're right, that placebo factor could certainly, because people believe they're going to get better, they may get better. The other thing I would say is, you brought it up before, is this transcranial magnetic stimulation, which I'm not as familiar with, but I have a guy, Dr. Sunder, coming on, I think on March 24th, to talk. He does a lot of that work in his clinic, and I'm really fascinated. I can't wait to pick his brain on this transcranial magnetic stimulation, which is a whole other topic that I really never heard of before I went down the rabbit hole.
Yeah, so Keithy is a good friend and a collaborator. I know he trained in Pittsburgh, one of the finest departments of psychiatry. He's really done it the right way. He's doing work here in Palm Springs, and he just opened clinics in India. I think what you said is really so important, is that if we understand what might be causing it, then we can come up with treatments. I use the analogy, if we don't understand what's causing something, the analogy would be, well, let me close my eyes, let me hold up a pistol, shoot it in the air, and hope a duck flies in front of the bullet. It might happen, but it's always a little bit better if we understand. And this idea of mitochondria, if we understand what is it's the energy driving force. And we go back to what we learned in medical school or even in high school, that the role of mitochondria. So I think what we need to do is, inflammation, there's a lot of good work going on, and not inflammation like I got an infection because I got a cut, but what's going on in the brain. So we're talking about the neuroinflammasome as being important in depression and anxiety. I think it plays an important role in concussion. What's happening in the brain that we're having cognitive difficulty, we can't remember, we're having some mood lability. So the more we understand about what might be leading to these symptoms, then we can step back and say, okay, whether it's dealing with mitochondria, the microbiome plays it. There's a whole lot going on the role of the gut microbiome. And people say, well, what kind of a craziness is that? But now we know that the gut microbiome plays a role in some of these things that we are now demonstrating are really important in regards to mood and thinking and ultimately behavior.
It's interesting because, Dr. Nussbaum is also, he's enamored by the microbiome. I didn't know that about him, and he's my partner. I didn't know that about him until I asked him the question on the podcast, and we did it in person. And afterwards, we spent about an hour talking about microbiome health. I did not know that is something that he's so passionate about. And people don't know, like, all the production of serotonin, 95% is produced in the gut. And if you disrupt these mechanisms by having dysbiosis, man, you're going down a different path. And I know there's a ton of work being done, for example, on like anxiety syndromes and depression and things, and looking at like ketogenic diets, which some people are huge proponents of, some people are not. And there's varying, and all these different specialties obviously are going to have different opinions. That's what makes our medical community so vibrant and so great, is that we kind of fight it out until we start seeing what works and what doesn't work. But yeah, the concept of the microbiome it is fascinating. I even started going down, like, looking at microbiome health in these symptoms, like in these women that have all these horrible cystitis type symptoms with no findings. And you look at the urinary microbiome and how that plays into these devastating syndromes that I mean, that ruins your life, right? Having constant cystitis, like they never get a break all day long. They're on they try everything. And so maybe, titrating that. So, I mean, again, I'm going down a whole different path. We need like
Yeah, no,
20
no,
hours to talk about this stuff.
and that's why it's so important, because the more we understand, and if it fits a particular model, I think we have to be cautious that the public doesn't view this as a way to sell a new gimmick, to sell a
Correct.
new, supplement or whatever, because and I think the internet, this is part of the two-edged sword with the internet. As we all know, the internet isn't peer reviewed. You can put anything you want on the internet. It could be fun. And the general public doesn't know, who do I believe? If some actor said it's good, well, did they go to medical school or do they have medical training, whatever? So this is part of the balance that we have with social media, with the internet. There's stuff that's out there that's good. I think what we need to do is exactly what you just said is, how does this make sense and where might we intervene? It's another tool in the toolbox. I believe the gut micro, I've been sold on it. Chuck Rezan, a colleague of mine, we published some stuff together, has done a lot of, and there are many people who've done really good work on this, but so why might it work? Again, I think we're going to see a whole lot more on this idea of CNS inflammation. And again, people think of an infection like, well, I just take an antibiotic. Well, there's some pretty good data on the role of ceftriaxone and substance abuse. The problem is, when you take it by mouth, it's too big. It can't get into the brain. So the studies have mainly been done in animal models. But you're so right that we need to keep an open mind. And how does it fit the model? And if it doesn't fit and it's working, then maybe we need to rethink our models. So whether it's mitochondrial functioning, whether it's gut microbiome, a whole host of things, they say, well, which one's right? Well, maybe they're all right. They're all pieces of this bigger puzzle. And what can we do? But I think keeping an open mind and doing the good work, that you're doing as a clinician and that researchers are doing, and listening to athletes and coaches and the community at large, then we have a chance to make a substantial difference moving forward.
PTSD and the way that it ties in. So a lot of these people that are, that have more TBI and major concussion, they also get into the PTSD. So there's this overlap, right? There's some overlap, but there's so many reasons to have PTSD. We could talk about PTSD for an entire episode, but really what I wanted to ask you about is, in the elite athletes, because they're under so much pressure, when they sustain a significant failure, so they let's just say they lose in the gold medal round, or they fall off of the balance beam, or they're part of the World Cup games and they miss a penalty shot. Have you seen like severe PTSD, like true PTSD symptoms develop that are hard to treat in these elite athletes? Because it's not talked about, their PTSD.
Absolutely. I mean, and you can look at the psychiatric criteria for PTSD, and it fits all of those. They have, nightmares. They have a hard time relaxing. They have flashbacks, missing it. So you're absolutely correct, that we can see that. One of the things I think with PTSD, and it is such a fascinating, it's kind of one of those things where an emotional event can trigger something that has very strong and significant biology, can't sleep. And then the not being able to sleep leads to, the development of other neurocognitive deficits, because we know good deep sleep, good restful sleep is really important for brain health. So that it's all really interconnected. And I've had people ask me about this. In fact, we've written about, the role of certain forms of psychotherapy in dealing with athletic PTSD. That it isn't just part of war neurosis, what it was originally written about, going back 100 or more years, but exactly the same thing. One of the things I think it's important for the audience to understand is, when we're looking at any major stressor, physical or emotional, there was a guy named Hans Selye who, he was like the father of stress medicine. And what he talked about was with stress, and he did it largely with laboratory animals, then got in humans, is when you have a chronic significant stress, physical or emotional, there's kind of one of three things that happen. Either one, the stress goes away, in which you're okay. I can stop. The problem with PTSD is it doesn't go away because you're having the nightmares. It affects something where it's there, and that's the PTSD. Or you develop a better sense of resilience, how to deal with it. So you say, okay, but this is going to help me in the next event, or it's going to help me be a better coach. So when the people coming behind me, so this way of increasing resilience and, a way of dealing with, so that this stress becomes more of what we used to call a eustress. Or If none of those happen and the stress continues, what Celia said is you die. Well, I think we're not having people who are dropping dead of this, but I think we die as far as our overall physical and emotional health. So I absolutely believe, and this is where we're working. I mean, the NFL, I give them credit. As a consultant, I'm not employed by the NFL, and I know a lot of people have a lot of issues with them, but for whatever reason, they are concerned with how an athlete's coming back from injury. The athletes who have retired, PTSD, absolutely from a sports perspective. And some of those same things that we know can be beneficial in a non-athlete that we, for example, are using in soldiers that can work there. And I think your awareness of that is spot on. And that what we need to do is sit down and have an athlete feel comfortable enough to talk about, what was it, and say, doc, I haven't had a good night's sleep. I'm in bed a lot, but I wake up and I'm wasted, or I'm finding I got to have a couple of drinks just to relax. Or, I just feel kind of crappy about myself. I'm not motivated. I feel like I'm a failure. I said, well, you've been a world-class athlete. So it's a classic textbook athletic presentation of PTSD that, if not addressed, I believe that more often than not will lead to other problems with functioning in life down the road, and some of them quite significant.
Some patients that undergo major surgeries end up having PTSD because of their experience. And it's everywhere, right? PTSD everywhere around us. It's just like concussion. You have to look for it. It's so fascinating.
Right.
When you are evaluating somebody for PTSD, let's say some of these scenarios you talked about, can't sleep, can't do this, can't do that. Are you more in that camp of more non-medication management, or is it a combination? Because I know that there are these camps that develop everywhere, just like the weight loss camps. There's guys like, oh, there's drugs for everything, and other people like never take a drug ever for any, So where are you somewhere where you just think that it's more of I'm an integrative guy, so I'm imagining it's integrative. And how do you start on those patients?
I always try to do it non-pharmacologically. The body is meant to heal itself. That what we're doing is we're essentially buying time, whether it's an antibiotic where we're buying time to let the body's own immune system kick in, or we're buying time because I think we sometimes underappreciate some of the side effects, and some of them are fairly subtle. But the question then becomes the level of impairment. So if someone is acutely suicidal, and I think I can get them stabilized, with TMS or whatever it might be. I'm not here to promote any, but I think a good clinician says, if someone comes into the emergency room and they're bleeding out and they have a sprained ankle, well, maybe you take care of the bleed and then you deal with the ankle later. So I'm of the belief that I like non-pharmacologic interventions, but I am happy that we have medications that may be helpful. And I think we have to use them cautiously and wisely. I am not an anti-drug person at all, but use them wisely. So I always say my rule of thumb is, what's the lowest dose that's effective for the shortest period of time? And I'm hoping the lowest dose is 0. But it's a tool in the toolbox that needs to be there. And hopefully it's the educated physician, clinician working with the patient, understanding that says, let's use we're talking about sleep. We know without doubt that there are medications, disease, as we all call them. Yeah, they'll help you get to sleep. But we also know that it's not the same quality of sleep.
Correct.
People should not be on these drugs for months on end, that we actually do pay a price. Like just falling asleep, it's really the quality of sleep is more important oftentimes than the quantity up to a point. So people are, all right, maybe we'll use these just to break that cycle so you can get back to a normal sleep cycle. But sleep that's induced through a medication or alcohol or anything else is never going to be of the health promoting quality of natural sleep. So I like to take a quote more natural approach. And people think, well, that's homeopathy. No, because at the end of the day, if the body can't do it itself, if you can't muster up an immune system, deal with an infection, you're going to be dead at some point. We try to buy time with our antibiotics. So long-winded answer, but I like the more what we might call conservative. I don't think they're conservative at all. I think really focusing on lifestyle issues can be a very, a fairly aggressive approach, but aggressive in a positive way. And again, I want to leave this point just so we don't miss it. When we're talking about exercise and sleeping, it's got to be fun. No one says, thou shalt do this, stop eating this, start eating it. But people, we don't like to be told what to do. We might do it out of fear, but to me, when I talk about the important role of exercise in mental health and physical health, I always talk about it can't just be, it's got to be fun exercise. If you enjoy going to the gym because you meet up with your buddies or the way you feel after you do a couple of good sets or whatever it might be, you're more likely to do it. And in fact, if you get some level of happiness and joy from it, it's got a more positive physiologic effect. It's not just the mental. Use drugs when you have to, and not as a total last resort, but going to a more wellness-oriented lifestyle psychiatry, lifestyle medicine approach, and then using medications when they're, I mean, we certainly wouldn't start someone on insulin who is pre-diabetic or who had type 2 diabetes. Should we not use insulin? No, we use it if someone needs, the beta cells in the pancreas aren't doing their thing anymore.
Right.
But the appropriate use of medication, but understanding why, not a knee-jerk reaction, like, oh, if you got this, take this, but understanding what is it doing and how might it help, and then close monitoring. I think too often we'll give somebody a 3-month supply, and a lot of stuff can happen in 3 months. So I'm not a big fan. You said I did ADHD research in clinic for a long time. I was never a fan of, well, here's a month's supply and I'll see you in a month. There's a lot of stuff that can happen within the body, within the mind, within, the world in which they're living. So I think medication should be appropriately monitored. We should be on the lowest dose that's effective for the shortest period of time. And we don't know what the answer to that is. The shortest period of time in the story of insulin is probably for life. You're not going to wean yourself off insulin if you're an insulin dependent diabetic. I like the fact that we are now in medicine, I think more and more looking at, it's not just, better living through chemistry, psychopharmacology. I like the fact that we continue to have some advances there, but what is the role of that piece of a puzzle in what hopefully is a much larger, multifaceted, many more pieces other than just medication?
It is a wonderful breath of fresh air to hear exactly what you're saying about limited use of medication. We took pharmacology class. Actually, it was one of my favorite. I mean, it's fascinating what has happened.
I was fascinated by it.
It's fascinating. I mean, I'm starting to read more about it now again. Just it's fascinating. As a spine surgeon, there's a limited number of medications, we give out. Unfortunately, one of them are opioids, which is a whole other discussion. But I think that, just limiting medications in all aspects and thinking about other ways, wellness ways and preventative ways, like you said, utilizing non-pharmacologic means to get people better. And then in emergency situations or when you really can't and you really need to, as a clinician, do that. Because like I said at the beginning, patients are on all these meds and sometimes they're on autopilot. So they start with 2 and then they're on 14. And if you ask them, they have no idea what they're on. And half the time, no one knows why they're on all these meds. I notice this as a surgeon, sometimes when they come and the anesthesiologist is like, your patient's on 16 meds. And I said, yeah, I know that, but their doctor approved them for surgery. And apparently they got a clean bill of health. So we'll go that direction. So I think all of us as a community really need to just really think about judicious use of medications. Like in our clinic, we've made a huge change in the 18 years I've been there in the way that we manage opioids on patients and have very strict criteria for who gets it and who doesn't and who gets transferred out to pain management clinics and things, because obviously we don't want to be part of that problem. And we've seen that. The other thing is, I love the fact that you did one of these with natural remedies, because I'll tell you, these labels of alternative medicine, what's alternative about microbiome health? What's alternative about, like dietary? It's not alternative. It's just Western medicine, pharmacology, interventions, the stuff I do, the guys that do injections, all these interventions. It's just one type of medicine. Meditation is medicine. Yoga is medicine. Of
course.
What we eat is food is medicine, right? One of my favorite things, food as medicine. I just love the guys that are out there pushing that. So thanks for bringing that up, because these labels of it's natural, it's alternative. It's not alternative. It's just something different. And one of the examples I gave is I said, if we have like a donut, and instead we just decide, you know what, I'm not going to eat that. I'm going to eat a banana. You just say, well, I'm going to eat a banana. You don't say, I'm going to have an alternative. Like it's a banana. It is what it is. So, what we're talking about, it's just what it is. It's a treatment.
And it's a terrific analogy because we put labels on things and then it's like we have camps, like you're for or against it. I remember for a while, I was like, are you a biological psychiatrist? And I said, no, I'm a psychiatrist. Hopefully I can understand the role. And I think medications clearly do have an important role. I mean, I've seen patients whose lives have been saved by being on appropriate doses of antipsychotics,
Of course.
antidepressants. So it's I call it my three bears analogy when it comes to, we don't want it too hot, i.e. too much, or too cold, never use when we should, but what's just right. And for me, I think understanding that there are other, it's just, unfortunately, it's so much easier to write another script than to work with getting somebody off it. And I think certainly in my field of psychiatry, I've seen one of the real pet peeves of mine and dismay is over the years, it's psychiatrists were being relegated to the role of just, the pill pushers, the medication. Well, send it to the psychiatrist, go see your therapist, but then go see your psychiatrist. I think we need to work together as a team. And again, get back to what pharmacology should be, that even though it is sometimes more difficult to get somebody off, I think that's a healthier way to go. So not like you should never use it, but use them appropriately. Don't use them when they're not in. And if they are indicated, what endpoints are we looking for? What are the cardinal symptoms that we want to see improvement in? So we know whether we maybe need to up the dose or lower that. Just serum blood levels is better than nothing. So I think this is hopefully something that will continue to change, because the reliance on medication, as opposed to relying on living a healthier lifestyle, dealing with stress in a way other than, taking a benzodiazepine if you're anxious, or taking an SSRI if you're sad. I mean, antidepressants aren't anti-sad drugs. They deal with some very specific things. And the more we educate each other and learn how to use these, I think the better off we're going to be in promoting wellness and quality of life.
That's wonderful. I just want to touch on the opioid crisis. Again, I would need you for about 4 hours to talk about that. I know you've done a great work also in conjunction with Dr. Bloom, who I'm actually having on the show. I'm excited to pick his brain.
I mean, really the father of the reward deficiency syndrome and understanding the genetics. But Ken is an absolutely fascinating guy, and I think you'll have a fun time with him on the show.
Yeah, it'll be fun. So I was going to ask you, so on this reward deficiency syndrome, which I've done a lot of reading on, listen, you guys have spent your whole lives. It's just like if you were to read on scoliosis surgery, there's only so much you're going to get in a week of doing research. But this reward deficiency syndrome theory. And I know some people kind of push back on it, saying it's too simplistic, whatever, in going there. But the thing that fascinates me about it is that it's interesting, because if you look at just the different genes that we're born with, it just goes into the way in these dysfunctions. And from my research, there's different areas that you can target down the pathway, from the way serotonin works to ultimately, the release of dopamine, kind of down that pathway. How much of the reward deficiency syndrome, that pathway, how do you use that to target pharmacology on your patients, or the way you treat, people that are addicted or kind of going down the opioid? Because I know it's for everything, right? It's just for obesity, all kinds of obsessive compulsive disorders and all kinds of things. So can you talk a little bit about that? Obviously, I'm going to have Bloom on, but a little bit about it and kind of how you use that, like, in practice.
So yeah, I've been involved with Ken, published quite a number of papers with him. I think what we're talking about with the reward deficiency syndrome, to take maybe one step backward, is what it's talking about is there are individuals who are at greater risk. We know this and all. We know people are at greater risk for developing cancer, that there's a genetic link. And maybe part of, and Ken has worked a lot on a test, that he talks about, the GARS test, which is to help identify people who might be at increased risk for having some of these issues down the road. I think what the RDS, for me, it's looking about the important role of having a balance. And this, I think, is true in all of medicine, that we talk about homeostasis, that's proper balance. So if we get cold, we shiver, it generates heat. If we get hot, we sweat, it evaporates, it cools us off. That the body is really meant, and there are many backup systems to that, to have this balance. So when we upset that balance, like if we can't sweat, if we can't shiver, then we run into issues. So RDS, and Ken will get into this, it's understanding that there's genetic reasons for this. It's not just a flaw in one's moral fiber. It's about getting this balance. The body always wants a balance. And as an orthopod, you clearly see this. If something is overdeveloped compared to something, it's that lack of balance that leads to certainly orthopods as well as neurosurgeons. But I think for me, what I like is having people understand that we're talking about opioids. And I go back I was on the LA County pain team back in the early 1980s. and we were looking at, we just developed a project at Western U where I'm at now, a number of years working with the California Dental Association. Turns out dentists, it's been a real issue with what they do is their standard practice. Kid goes in for molar surgery or to get their wisdom teeth extracted. They were giving them too high a doses that they probably didn't need of opioids. And for a certain population, increasing the risk of maybe having issues down the road. So now every dentist in the state of California goes through, and I know there are other parts of the country as well, on just core education. How do you manage pain associated with it? Do you have to go right to an opioid? Can you use non-steroidals? Can you use other analgesics? So the opioid crisis is very complex, but unfortunately, a lot of it, we have to look back into the mirror as providers.
Yes.
Were we using these drugs appropriately? Should we never use opioids? No, I think there is absolutely a place for them, but it should be fairly limited. And after a really thought, it shouldn't be a knee jerk. Well, someone had, their left molar taken out. Let's put them on a couple, 3 days, or they were even on it longer than they needed to be, so that there is a downside. So the opioid crisis, a lot of stuff going on with that. And again, we could do a whole few hours on that. But I think it gets back to what we were just discussing, is that this is a pretty powerful tool. Let's only pull it out.
Mm-hmm.
You're not going to kill a fly on the wall with a 22 caliber gun. You hopefully start with a fly swatter. I think that what we need to do is understanding, not just have it be a need, and that there is a downside and can be a significant downside. And it's more so in some than others. So like I tell people, caffeine. My wife can drink a cup of coffee and be asleep in 10 minutes. If I have a cup of caffeinated coffee after 2, 3 in the afternoon, up till 2 a.m. And it's been that way for my mom, and we never had. So we all have different genetic vulnerabilities. Yes. And I think part of what what Ken talks about with the RDS is that there are these genetic things that are affected by non-genetic things, epigenetics, kind of, stresses in our life and a whole bunch of other things. So I like the idea of destigmatizing it and getting back to what I believe is such a critical part of health and wellness, and that's having the right balance. You don't want to be in bed 20 hours a day, but 3 hours a day probably isn't enough. You don't want to be guzzling, 6 gallons of water a day. But what's the proper amount? And as we get further down the road in personalized and precision medicine, what's right for you? What's the right workout for you, given where you are now with your age and everything else? That's where I'd like us to get, so it's not just that knee jerk. And I think you'll have a lot of fun with Ken, but the idea of balance in life, whether it's as an orthopod, as a general internist, as a psychiatrist, that to me is a very important concept. And anything we can do to allow the body to get back into a natural balance is going to be health promoting.
Getting that balance, but trying to do it as naturally as we can. What's fascinating about
that's what's going to sustain it. If it's not done naturally, it won't be sustained, because as soon as you stop the drug, you're going back. So if we don't get that balance, it's not going to be a long-term fix or improvement. And we don't want to see people on drugs lifelong, unless, diabetes, insulin would be the one, there might be some others in there, but that the goal should be quality of life is about, can we get the body back where maybe the body just needs a little bit of help with it, as opposed to being dependent on, and I'm not talking about drug dependence per se, but having to have all these medications. Sometimes we start using drugs to treat side effects of other drugs they're on.
I talk about that all the time. It's these downstream effects. I mean, these people with this poor metabolic health, then they're put on drugs, and then that screws up another system, and it goes on and on and on. But yet we're not really getting to the root causes of what it is. Now, whether that is turning on their epigenetics or whether it's their new whatever, it's really a combination of so many different factors, which makes it fascinating. Like it's hard to wrap one's mind around how all the systems need to be in balance in order for the machine to work properly, right? Like anything, like if just a couple parts of your car are off balance, you might not be able to drive out of the lot. The rest is in perfect shape.
Exactly,
it looks perfect. Most beautiful car ever, but you can't, it doesn't drive.
And I think with age, as we're living longer, we talked about this earlier about quality versus quantity of life. But as we age, we know that the body's ability to handle it, a 20-year-old, a 30-year-old, a 40-year-old will be able to handle things differently than a 50, 60, 70, 80, 90-year-old. So understanding with aging that certain things are normal, should we be treating as pathology as a normal part of aging? Aging isn't a disease. If it is, it's a disease I'm hoping to have, but I think it's understanding that context and knowing that we're going to treat an adolescent differently than we treat a young adult. But the brain, it changes as we get older. We can't tolerate things that we were able to tolerate.
Right.
You know, I mean, that's why I think, you see pro athletes, by the time you're in your early 30s, you're getting to be an old man or an old woman because the body, it's still a healthy body, but the body changes as we age. It's not a disease. It's just a fact of life. So there's so much right on the important issue of wellness throughout the life cycle requires an understanding of maintaining a healthy life balance, whether it's nutrition, exercise, stress management, social relationships. I mean, our own Surgeon General, Murthy came out there. He said, the number one public health issue was loneliness.
100%.
Not as an emotional, but as part of health and what it does to our to our core physiology. So I think we're making strides. I think podcasts like this that get out there have people thinking, what should I be asking? I don't think we should be preaching to people, thou shalt do this, this, and this.
Yes.
But let's be thinking about this. Let's keep an open mind to ways to intervene other than what's the next medication to use. Use them when they're indicated. But to me, the goal should be, what's the end game to get off these? And again, some illnesses, chronic diseases, you might need to take them. But I'm always happiest when I can either do the work to get someone off and have them be at the same level or hopefully even a higher level of functioning, not being exposed to the meds. Because meds aren't evil, but using meds improperly, it's not the meds problem, it's the education of the provider. So we need to be thoughtful and think this through. And how does this fit in to an overall treatment strategy, as you've mentioned?
As we kind of get towards the end here, I love this idea. We touched on it before a little bit, but I love this idea of lifestyle medicine, lifestyle psychiatry, just looking at the totality of how people are living their lives and making sure that everything is really in balance. And you've touched on so many amazing, I think this is going to be wildly educational. I'm going to pull people to the side and say, you got to listen to Dr. Barron talk about these things because, you're saying it in such an easy to digest format. And it's so spot on to what people just need to hear because they're confused, right? They're seeing commercials on TV for every drug under the sun. You hit on it. They're going on social media and they're getting bombarded. Oh, this product. Oh, if you take this, this vitamin, you'll be cured. And if you do this therapy, you'll be perfect. And there's just so much information. And the truth is, just coming to get homeostasis and balance. One thing that you were just talking about is getting people off of medications as a thing. There's a guy on LinkedIn, I'm not connected. It's interesting. He's a physician and his tagline is, I got to go back and find out who it is because it's just brilliant. I just read it the other day. Good physicians know how to use medicines. Great physicians know how to take people off of medicines.
I could not agree more. And again, it's not to be anti-pharma. And the other thing, and again, I know we're just about out of time, but the thing I love about lifestyle medicine and lifestyle psychiatry, it's not something you need to have the world's expert in it. These are things that you can do with yourself, for yourself. I can identify what's a fun way to get some exercise. Not like I got to go jog because my doc told me but I can take control. We've done lifestyle psychiatry programs in the jungles of Borneo. Just a year and a half ago, I lived there with my wife. We went over there and, we would get, people in the doing healthy lifestyle, psychiatric. And we, there are two psychiatrists for 2.5 million people and nobody out in the jungle. But the thing I like about it is it gives you a sense of taking control of your life, not feeling guilty about it, but what can I do to live a healthier, more enjoyable, happier life? There's nothing the matter with seeking happiness. If you only get happy when you're getting stoned, well, then we got some issues there. But seeking health and happiness and feeling good about and knowing that I've taken control of this. I'm not worrying about having what my doctor tells me, what's said on the internet. But I know if I'm getting a good, restful night's sleep, if I'm socially connected, if I have some ways of dealing with all the stresses in life. People say, what's a stress-free state? I said, well, there's one stress-free state. It's called death. As far as I know, we're not stressed when we're dying. But otherwise, the world is stressed. How can we deal with that? How can we take control? And there's some simple things that you don't need to have access to the world's greatest medicines, but that we can do that can help promote that. And that's why I think this idea of wellness, of seeking joy and happiness in a healthy way, because that is maybe one of the most powerful biological interventions we have.
last thing, and one of the things that is sort of disheartening to me, and one of the things that played into me doing this, other than what we talked about before, people really not understanding, the damage they do to their systems, exposed to different toxins and food types and things like that. Again, each one of those is an entire podcast, right? We could just talk about even 5G towers and potentially how that can affect, cellular health. But one of the things that honestly, I don't have another word, but it's heartbreaking to me, is when I see people that are, to me, they're still young. They're in their 50s or 40. I mean, they're young. These are young people in today's with modern medicine. You're young. You got a long time unless you die of some other thing. And this is I think a great question to ask, a world-renowned psychiatrist. How do we get them out of thinking that that's it? They're supposed to be this way. And that many of them just come in and they're on all these meds. They don't feel well. They might not have a syndrome. They might not have a defined disease. They might not have full-blown diabetes, or they might not be morbidly obese. They might not have any of those things, but they feel they're miserable. But they feel like that's the norm. They're like, well, I'm 52 years old. This is just the way it is. Or I'm 62, or I'm 42. My friends are like this. We're all miserable. After a certain age, it's over. And I'm just going to have this existence for the next 30 years, pretty much just not feeling well, being miserable, and seeking some kind of medical care, most of which is going to be through pharmacological intervention. What do you tell those people? Because when I see them and they've given up, I'm like, it's pretty early to give up. You got a long, long way to go.
What I do is I try to challenge it in a way without being challenging. So I say, you really seem demoralized with this. And I can understand it. Maybe can't play the golf you used to play, or you can't swing a tennis score, whatever it might be. Isn't it a shame that we're so youth oriented about this? But then I'll say, but you know what? I think there's some things that maybe we might want to talk about or have you think about. You don't have to come in psychotherapy for this, but there's really some good emerging stuff that the quality of life is important. And you know what I'm interested in? I'm interested in you being happy. I'm interested in you enjoying your life. And you know what? Maybe you're not going to, be a scratch golfer, or you're not going to be able to swim 2 miles in the gym. But you know what? Life and enjoying life. This is something that you can do if you choose. It's your choice. It seems to me that you're kind of down on things, and as your doctor, as your someone who cares about you and your health, I want us to see if there's maybe another alternative here. And why aren't you feeling this way? I mean, I want you to be able to enjoy those things in life. And I want you to think about things. What is it you really want to do? Whether it's engaging with your kids or your friends or whoever it might be. So you're right. The autopilot for some of these people is, yep, it's, ball game's over. I'm just, sitting around waiting to die. I think challenging that and telling people, no, you know what? With age sometimes comes wisdom, the ability to appreciate, highlighting that aging is not a disease. Yeah, maybe your vision's not quite so good. Maybe you don't hear quite so well, but does that mean that you're blind or you're deaf? That you bring a perspective that life brings in, the ability to share. I often talk about Eastern religions where they really revere aging, and we're a very youth-oriented Western, certainly in the US, everything's about youth and, strength. But sometimes it's the wisdom that age comes with. So I think you're right. I think identifying that this is a way that we in the health profession, as a physician, as a psychiatrist, whatever, we need to be looking at what goes into a quality of life. It's not just having a heart that's beating 72 beats a minute, or a BP that's 120/80, or a blood sugar that's 75, go all the biomarkers that we measure. But what can we do to evaluate how a patient is feeling and enjoying and having some level of happiness, enjoying their life? And what can we do to make that better? And I think we add to it by not asking, hey, are you still enjoying it? Nah, yeah, it's been a while. Why not? What are you doing for yourself? What are you doing to go out and have fun? When's the last time you went out and had some fun? It's been a while. Yeah, I'm an old guy. I'm an old lady now. Bull. You know what? Do you want to still do? So let's talk about what you can do to go out and have fun and enjoy. Because when you're having fun and enjoying things, your life's going to be better. And the people who care about you, if you can't do it for yourself right away, do it for them, because they're going to feel better when they see mom or dad or, whoever. Hey, geez, you look like your old self. You're going to make them feel better. So if you can't do it for yourself right now, maybe you can start by doing it for them. And if people are to the point where they have no capacity to enjoy anymore, then we got to start thinking about dealing with people that I work with. Maybe there's some other things going on, because the disease of depression, not just feeling sad or demoralized,
Right.
is out there. It's a real disease. So, that's more like, you're not pre-diabetic, but maybe you're getting to the point where we do need some other interventions. But I think that challenge, not allowing people or challenging them not to say, do you still want to feel, yeah, I'd like to, but I can't. Hey, let's work together to fix that. If someone says, no, I don't deserve to feel happy, I've not done that. Yeah, then we're talking about another intervention.
Yes,
And maybe Keith, Dr. Sunder will talk about TMS, and our TMS when you have the next podcast with him.
That's a great answer. And I think that from a kind of a mental, emotional standpoint, which is what you're talking about, I love that answer. I'm going to actually use that. I'm going to, now that I have this recorded, I know exactly what to tell my, because I say it in my way, but you've said it. It's just amazing. Getting them out of that vicious cycle, that downward spiral, because if you don't feel well mentally and emotionally, it then feeds into what you eat, how you eat it, how much sugar intake.
Absolutely.
You don't exercise, and that's the vicious cycle. We want to get them into what you're talking about, which is the virtuous cycle, where they start feeling mentally better. Yeah, I'm excited. You know what? I'm going to do this for my grandkid, and then all of a sudden they're at the, they're taking their walks, and they're eating healthier, and they're trying, different things to make their overall health better. And I love the fact that you hit on it. It's got to be fun. And it is amazing if they can do it in an environment where they have unsocial networks. So like, I've talked to people, I've talked to like square dancing associations and stuff like that, and they love it. It just changes everything for them.
Yeah, we're just starting a new project up in Lebanon, Oregon. It's a small rural town. We have one of our campuses up there. We just got the protocol approved. We're doing water yoga in geriatric population. It's actually, we did a Tai Chi study in Malaysia, and what you see, these old folk coming down, they go through full range of, and then they go have a cup of tea and talk about their kids or, what was ever going on. So this social connectedness as part of exercise, feeling connected to yourself and your community. And that's why I love the wellness. I love to because we tend to do things that make us happier. If that is a healthy thing, we're going to be promoting it without doing it because, well, I love to smoke, but I stopped smoking because I'm afraid of dying. That's why we, the recidivist, or, I stopped drinking because I was afraid of, but that's the one thing that made me happy. So, we get back to rewards, a reward making you feel good versus a negative reinforcer just takes away a bad. I would love to, if I leave anything in this back end of my career and I still love what I'm doing, I'm passionate about it, but to get people to understand the role of seeking happiness and having something feel good that, I can feel good about what I'm doing, and I'm doing it for me and the people that I love and care about.
Les Brown, who is this motivational speaker, he said it best. He goes on this big, long thing, and at the end, he's like, well, if you can't be happy, what else is there? Ultimately, that's the goal of enjoying this little bit of time that that we're blessed with to be on this thing we call life. And it's just happiness. And thank you for all the studying of the neurochemicals of happiness and everything. And I mean, kudos to you. I mean, your career is just, it's a marvel. And I mean, it's amazing. And I have to say that what you said before about being, humble, and it's not true. I think you've made a huge impact actually in your field and the way that people think about some of these issues. And, in closing, I want to know how can people, if they want to learn more about what you've done, what's the best route to get a hold of you? If not like looking, reading your articles and going down, looking at your books and things, like how do they find you?
Well, I mean, I get a lot of emails from folks. They can email me. It's a real simple email address. It's dbaron, DBARON @westernu.edu. That's the current university I'm with. And I want to thank you not only for those comments, but this really is a team. When we're talking about doing this, you don't win a Super Bowl with 11 Patrick Mahomes, recent history. You need him, but you need some linemen. You need somebody who can make a kick. You need somebody who can block. And I think we're in this team. So I very much appreciate the kind comments you made, but I am just part of a team. For me, the greatest joy I get now is being able to train and have an impact on the next generation, who I have no doubt will do far better work than I ever did. They'll take the bar to the next level. I'm thankful for the trainers and the mentors that I've had throughout my career, so many of them. I'm thankful to be able to make a contribution at a public level with something like you, who've taken the initiative to go out. I mean, what good is it? It becomes state of the shelf science if no one reads it or hears about it. So we're all part of this team. And hopefully we can all feel good about what we do together because we're committed to this quality of life, which I think that's why we go into the health professions, regardless, why we hopefully get into, public policy. We want to create something that's better for the people that we live with, whether it's our own little community or the global community. So let me thank you for what you've done, for allowing me to be a part of this, and your very kind comments. But I truly believe it's, sometimes maybe the quarterback gets a little bit more credit for it, but I've seen some really good quarterbacks who had lousy seasons because their O-lineman got hurt and they were getting, they had 2 seconds to throw the ball as opposed to having, 5 or 6. So it's a team approach. I like the fact that we're looking at some concepts that may be a little bit different, like focusing on wellness and happiness and lifestyle issues and, kind of not so much taking responsibility, but choosing to do things that we know and then getting that reinforcement. We're all just so lucky to be a part of this. So thank you so much. And certainly all the best of luck. I look forward to seeing and maybe even contributing to future podcasts down the road.
Well, thanks, because you just took that out of my head. I think that people that watch this podcast, they're going to want to hear more about some of these topics that we talked about today. And it's been a fascinating discussion. So I thank you from the bottom of my heart.
It's been a lot of fun, and I hope of some value for your listeners. And it's been great interacting with you. And enjoy the rest of your day. And we look forward to working together in the future.
All right. You as well.